Hello, good morning. My name is Roxana Watts, and I am a student of the Bachelor's Science of Nursing class at Southwest University, and I will be presenting to you the effects of asthma on population. The objectives for this presentation are going to be identifying asthma exacerbations to prevent hospitalization, educating patients and their families about the disease process, and identify those who are at risk of developing the disease. For the disease overview and population of community, we're going to go over pathology of asthma, anatomy, overview types, and community population. So to begin with, we're going to define what asthma is. Asthma is a chronic condition that affects the airways and the lungs. The airway may become narrow, cause swelling, and produce extra mucus, which may make it difficult for the patient to breathe. This can be sometimes called air trapping. Asthma symptoms are driven by the inflammation of the airways, which triggers processes such as mucus production, remodeling of the airway wall, and bronchial hyperresponsiveness, which is a tendency of the smooth muscle cells to react to nonspecific stimuli, such as cold air. A normal airway has bands of smooth muscle around the outside, as well as some muscle within the tunica of the vessels. A healthy pink lining on the inside of the airways is normal with a thin layer of mucus that helps to protect the airway. The thin layer of mucus in the airway creates a slippery environment to clear the airway's foreign particles and irritants. Air is easily able to travel through the airway passage. People with asthma have sensitive airways as they react to triggers, which may cause their asthma to flare up. Changes can narrow the airway opening if a sensitive airway reacts to a trigger. The airway becomes inflamed, then the walls of the airway become red and swollen. The airway may also produce excess mucus, which causes the airway to narrow further, reducing the space inside the airway through which the air can travel. The muscle bands around the airway may also tighten, reducing the size of the airway even further. Any of these three changes can occur with an asthma attack: airway inflammation, excess mucus production, and muscle tightening can be difficult to move air in and out of the lungs. A person with one or more airway changes may experience asthma signs and symptoms. While classifications of types can vary, some different types of asthma are going to be broken into the following: allergic and non-allergic. In the case of allergic asthma, your lungs are sensitive to a specific environmental cause. Once that enters into your system, your body tends to overreact, causing inflammation in your lungs, making it hard to breathe. Some causes of allergic asthma can include pollen, grasses, weeds, mold, animal dander, dust mite, and cockroach species. In the non-allergic asthma, which usually happens after midlife, it can be caused by recurrent respiratory infections. Another type is aspirin-induced asthma. It is an aggressive inflammatory disease in which asthma is combined with rhinitis with the aspirin ingestion and most NSAIDs. The disease is not found in asthmatic children. Also, the main symptoms of cough variant asthma is a dry cough. These people have no other classic asthma symptoms, and it is one of the most common causes of chronic cough, lasting anywhere between 6 and 8 weeks. Exercise-induced asthma is the bronchoconstriction occurs when people engage in physical exertion that narrows the airway. And nocturnal exacerbation of asthma is closely linked to circadian rhythm. However, not much is known about why this happens. If a patient needs high doses of steroids or has suddenly stopped responding to this class of medications, it is known as steroid-resistant asthma. It is thought that this patient possibly was wrongly diagnosed with asthma. Occupational asthma is when symptoms are triggered by chemicals a person is exposed to at work. And generally, the patient was not known to be an asthmatic patient prior to this. For the community population, we're going to be talking about childhood onset and adolescence onsets. Asthma often starts at a young age, childhood onset asthma, but for some patients, it can develop asthma in later in life or late onset asthma. Allergic asthma begins in childhood and is also been seen in other allergic conditions such as atopic dermatitis or allergic rhinitis. This form of asthma is induced by early life encounters with environmental allergens such as house dust mites, pollen, cockroach, and or animal dander, but it can also be induced later in life. The incidence of asthma was most significant in young children and was least significant in late adolescence and increased again in early adulthood. Epidemiology of asthma. Epidemiology studies the allocation and factors of health and disease in the human population. Results from the research studies conducted in specific diseases. The prevalence of the disease is significantly higher in African Americans and ethnic minorities. The explanation for this might be based on multiple factors, including inherited, ecological influences, urban influences, poverty, and the lack of access to healthcare. African American and Hispanic communities experience high levels of long-term stress, which may increase asthma risk through direct effects of the immune system, healthcare, and hypothalamic pituitary adrenocortical activation. Long-term stress may also mediate the effects of social determinants of health on asthma. Obesity is also directly linked to asthma due to high calorie intake and lack of exercise, causing thicker tissues and reduced airways. While the causes on asthma remain unclear, children that are exposed to second-hand tobacco smoke exposure are at increased risk for acute lower respiratory tract infections, such as bronchitis. Children living near or at poverty level are more likely to have high levels of blood cotinine, a breakdown product of nicotine, than children living in higher income families. Puerto Rican children are 3 times as likely to have asthma as compared to non-Hispanic whites. Hispanics are affected by high inflammatory food intake. Surrounding a pregnant woman may place at risk the unborn child for asthma. There is evidence that racial and ethnic inequities and social determinants of health, such as socioeconomic status, neighborhood environment, housing, environmental exposures, access to quality, contribute to the access to burden of asthma prevalence, morbidity, and exacerbations, as well as abnormal lung function among specific populations. Another micropopulation that seems to be affected is not so much the pregnancies, but the unborn children of pregnant women. The health of the mother plays an imperative role in the development of the fetus. Some of the maternal pregnancy diagnoses that place um, their offspring at risk for developing asthma are hypertension, preeclampsia, and anemia. And they're also related to the medication treatment that the mother is put while pregnant. The use of long-term antibiotic during pregnancy, along with familial disease, is correlated with the presence of asthma. Maternal smoking during pregnancy is directly associated with increased asthma in the baby. Not only active, but also passive smoking, meaning the people that surround a pregnant woman may place at risk the unborn child for asthma. An overview covered here will start with access to healthcare, language barriers, physician and healthcare inadequacies, such as a lack of local pediatricians and extended appointment times. Lastly, there are common triggers, causes, and access to medications and treatments. Primarily, El Paso City and County are both composed of Latino and Hispanic communities and have significantly lower rates of asthma than any other U.S. racial group. Latino children are more likely to be hospitalized or die from asthma than any other ethnicity. The burden to asthma is more significant in the Latino population because parents tend to be in the lower income bracket, in which case most of them do not have insurance, making it harder for them to seek medical care while uninsured. Many of them opt to receive care in Juarez. However, this makes continuation of care harder for them. Even while insured, some patients struggle to connect with pediatricians that don't understand their cultural backgrounds and that don't empathize with them. If parents are foreign nationals and undocumented, the odds are that parents will not be seeking medical help, therefore delaying care and waiting until symptoms are severe to take their children to the emergency department for further treatment and stabilization. Poorer parents are at risk of lower levels of education and lower incomes, as well as being unemployed and are at risk of higher poverty levels than any other U.S. population. Cultural practices might interfere with Latinos. Grandmothers, in the attempt to help their grandchildren to breathe, may give them some herbal remedies. The lack of pediatrician offices characterizes the lower valley in El Paso. Many parents in this area must travel to the east side, central, or west side of town to receive care for their children. Some children live with grandparents and sadly are unable to drive due to the advanced age or physical impediments, making it difficult for children to receive proper treatment. Latino communities tend to be marginalized in poor areas of the city, such as the lower valley in El Paso, where pollution might be higher due to the proximity to the border. Exposure to dust, chemicals, and mold might contribute to asthma. Many medications for asthma might be expensive if parents are uninsured, leaving them unable to obtain such medicines for their children, making them prone to hospital visits. Patients may report other problems, such as extended times to see a physician. Pitfalls in this area commonly occur with other advanced care providers, such as physician assistants or nurse practitioners, who are the only ones available. If patients cannot get all questions answered, a less than ideal or failure care may ensue. It is important to first define evidence-based practice, after which an example of past treatments and continued corrections we use today are warranted. Next will be example of everyday evidence-based changes that are commonly in use by all healthcare staff. Evidence-based practice is essential for nurses because it is the foundation for safe and effective nursing care based on the best available evidence, not personal opinions and biases. It involves combining one's knowledge and patient's condition with existing research to make the best decisions. It involves identifying a problem, finding quality evidence to support a solution, and combining that evidence with our knowledge to guide decisions. As noted in many medical texts of early 19th century, tobacco was once thought to possess healing potential. The distribution methods were everything from smoking to drops, injections, tinctures, and they were thought to be effective in preventing and curing asthma, among any other ailments. According to the Emergency Care of Transportation of the Sick and Injured book, here are some examples of pre-hospital treatments that are no longer commonly used with regards to pre-hospital care of asthma. The first one was to allow the patient to sit or lie down during an asthma attack during transportation to the hospital. The usual suggested advice was to provide the patient with several glasses of water during an asthma attack while in transit. Today, it is common knowledge that the use of tobacco in the event of an asthma attack would not be an improvement, and it actually can make things worse. An example of evidence-based practice changes all healthcare providers are required to share is when they are all required to the biennial training class of the cardiopulmonary resuscitation training. Every 5 years, with the next release date of 2025, the American Heart Association will release this comprehensive revision for adults, pediatric, and neonatal resuscitation education. Today, we are changing the care of patients as science, medicine, and research are produced through evidence-based practice. It is advisable to inform patients of new and ongoing research so that they may be diligent and with their asthma management and treatments. Short-term goals would be to maintain an optimal breathing pattern, no signs of respiratory compromise, and displaying normal vital signs. Demonstrate improved ventilation as well. The long-term goals would be to verbalize understanding of the education given to the patient, demonstrate behaviors to improve airway, participate in the treatment regimen, maintain airway patency, and prevent exacerbations. The assessment will compromise assessing the patient's respiratory status by monitoring the severity of the symptoms. An assessment will consist of breathing sounds and peak flow if possible. The last step in plan of care is the patient's maintenance and patient education and goal of limiting attacks. Maintenance and patient education. Long term is weight loss, smoking cessation, occupational change, and self monitoring. Um, are all critical in preventing disease progression and reducing the number of acute attacks. Importance should be placed on avoiding triggers, allergens, and exposures to other persons with respiratory infections. Our overall desired goal is to improve gas exchange. The patient will be able to maintain airway patency and improve airway clearance, as evidenced by being able to expectorate phlegm effectively, having an adequate respiratory rate and oxygen saturation, and verbalizing ease of breathing. A significant challenge is to implement the basic asthma management principles at the home and community level. Visiting the patient's home by the healthcare provider or community nurse will assess the environment of the house of allergens that may be indicated for patients with recurrent exacerbations. In conclusion, people with asthma can lead active and healthy lives with proper treatment and lifestyle modifications. Working with a healthcare provider to develop an individualized plan remain vigilant about avoiding triggers is essential. With today's wealth of instant and false information through social media outlets, it is essential to answer questions and dispel myths. Obtain educational materials that are relevant to current for the patient based on the patient's diagnosis, causes, level of education, and background and culture. They should also teach patients how to start an action plan and how and when to call for an emergency medical services or seek assistance.